Okay, so we're going to talk about glaucoma, which hasn't been covered yet, so maybe this will be new to you. So glaucoma certainly is a potentially vision-threatening condition. It's common in aniridia, and I'll come back to that briefly. Any age may be affected, and I'll come back to that briefly, but usually it's in sort of mid-childhood, early to mid-childhood when it occurs. Treatments are effective, of course, but new treatments are being developed, which I hope are going to be helpful. And certainly, as you just heard, other problems may require treatments at the same time. One of the topics I really need to talk about briefly is the mechanism of glaucoma and aniridia, because there's some old information that really is now thought to be inaccurate, and the field has changed considerably, and yet we still have a lot of residents and a lot of physicians being taught the old, a couple of, well, really 3 old papers that really produced a very significant error in the conclusions. And it's been perpetuated through years. So I'm going to talk about the mechanism first briefly, then I'll move on to the surgery, which is a very interesting topic right now to us. So infantile glaucoma, first of all, is pretty uncommon. It's thought to be fairly similar to congenital glaucoma, where there's an iridotrabecular dysgenesis. There's perhaps a little bit of an anterior iris insertion, and also absence of Schlemm's canal has been documented in the past as well. But this is quite uncommon. It's sort of less than 1% of patients that I see that are born with glaucoma. Most common thing is early childhood, maybe early adulthood patients will develop glaucoma. This is almost always an open angle glaucoma. Certainly there are patients with a secondary glaucoma if they've had prior glaucoma, any kind of surgery, anterior segment surgeries we just heard. Anything can cause this, and basically that also occurs, but again, relatively low frequency. And then there's this concept of chronic progressive angle closure glaucoma that I just wanted to touch on briefly. This really was perpetuated from a couple of papers, but it's somehow stuck from one series of patients actually that was published 3 times. And in this series, the patients were treated with really old medicines, actually most of them, Diamox, oral acetazolamide, and then epinephrine and pilocarpine. And as we all know, those alone can cause some angle closure because they're chronic inflammatory drugs. We don't even really use them anymore. And then the main problem, though, is in this series, the patients were consistently treated even before they developed an intraocular pressure elevation with goniotomy. And many of them had more than one goniotomy, some up to 3 to 4 goniotomy procedures. And in fact, the average amount of treatment that was done for each of these patients in the final series that summarized all of them was about 200 degrees of angle. That's a lot of angle to treat with a goniotomy. You have to do 2 or 3 times to get 90 degrees each time. You have to do a couple times to get that. So these patients were treated extensively with goniotomy, and we've always had this feeling that may have been a very significant factor in their conclusions. And certainly clinicians that care for glaucoma and aniridia patients, and I keep in touch with all of the United States, there's a handful. They've had the subjective and anecdotal impression that patients almost always have open anterior chamber angles and progressive angle closures rarely seen. So this paper was published a couple years ago, but 2019 I think, but it showed pretty conclusively in my view, of course I wrote it, I'm a bit biased, but that we're using anterior segment OCT and using gonioscopy in these patients, we found that the majority of eyes with aniridia and glaucoma, they had glaucoma and aniridia, had open anterior chamber angles. Very similar to patients that had aniridia without glaucoma. They just kind of looked the same. And then eyes with aniridia and glaucoma that had closed angles, and this is a very small percent, actually had a prior history of ocular surgery. Every single one of them. There was only like a small percentage of patients that had prior surgery, but they all had angle closure, and that very likely contributed to angle closure glaucoma in those small percentage of patients. This is some typical data that we looked at. So here's the OCT with an open angle in aniridia on the left, upper left, and on the upper right there's an angle that's closed. You can see the little asterisk there. There's a closed angle there. And the image on the lower left is just simply a patient that has aniridia and glaucoma, had an open angle, but you can see the corneal opacity. So this is where the anterior segment OCT is very useful, because you can actually really see the angle even though you've got that. So, our findings were not consistent with the previous, earliest literature on this topic. The issue is that goniosurgery was common and repeatedly performed in the previous series that was sort of considered to be, accurate. And the medications were also completely different. So we suspected that there was a problem with that earlier series, because certainly we don't find that now. But our findings are, importantly, our findings are consistent with other pathological findings when histopathology has been observed, and this was reviewed in 1984 by George Spaeth and his colleagues, Curtis Margot, and they were not able to document any evidence of a progressive angle closure or any adhesions at all in these patients. They found that they had essentially an open angle that looked fairly normal histologically, except for the short iris, right, just aniridia. So to summarize this study, basically the majority of eyes with Aniridic glaucoma have open anterior chamber angles, and eyes that had closed angles had a prior history of ocular surgery, which likely contributed to development of angle closure. And the key thing here is that aniridia, it was just mentioned in the previous talk, which was excellent, that aniridia is a pro-fibrotic syndrome, as we call it, pro-fibrotic. So if you do a lot of surgeries to the patients, they'll have angle closure that's secondary to the prior surgery or whatever, because they react with a lot of inflammation to these things. So this has important implications for scientists and clinicians to just understand that they have open angles, generally speaking, until you start doing surgery on them. So the next thing is that it is common. Okay, so this is from a previous study that we published from a large number of aniridia patients and found about a 50% rate of glaucoma in this population. The median age, which tells you that when 50% of the patients have glaucoma, is 8.5 years in this series. That's a large number of patients, so it's pretty accurate. It means roughly half the patients that you see with aniridia will have glaucoma by the time they're 8.5 years old. Now, I want to get to treatment just to finish up here, because that's a lot of things happening there that are part of a general trend and also part of a specific interest in this area. Medical treatment is done in about 75% of patients with aniridia in our studies, and it can be very effective. Laser treatments for open angle glaucoma are not effective in this population, so should be avoided. Incisional surgery is done in about 50% of patients with aniridia from our series. And most commonly now, the standard of care is probably glaucoma drainage implants. That's the most common approach used to treat aniridic glaucoma at this point. And it's a very good procedure. There's nothing wrong with it. But we're sort of entering a new phase of glaucoma surgeries, MIGS. MIGS, you know, the concept that we're having now is MIGS are minimally invasive glaucoma surgery, minimally invasive. That means you should have less scleral dissection. It's kind of a subjective thing. It should have a shorter surgical time. Patients should recover faster. It should be safer, and it should be hopefully effective. Maybe not as effective, but hopefully effective. And some of them are they're documented to be as effective as trabeculectomy. So the impact of this has been enormous in the United States. We've now had, in 1978, when our entire population was surveyed for what percentage of procedures are MIGS and drainage implants and trabeculectomy, our entire US population, government covered, private patients, self-pay patients, everybody in the United States was surveyed through a large database. And we found that at that time in 2017, MIGS were now 78% of all surgery, all glaucoma surgery performed in the United States. A large percentage of the remainder was glaucoma drainage implants, and trabeculectomy was almost gone in 2017. 2022, 5 years later, it's about to be resurveyed, but the expectation is it will be everything except for drainage implants will probably be MIGS with a very small remaining percentage of trabeculectomy. So, did I go ahead by accident there? Yeah, I got to say something about this. Sorry, I had to go back there one, Dan, I'm sorry. So, angle surgery, there's two different broad categories of MIGS. We've had some experience with this with aniridia, obviously. We have the trabecs, trabeculectomy, all kinds of angle surgeries, plus we have devices we can put in the angle. The hydrus, the iStent are examples of that. There's a lot of concern about those in aniridia because, again, we already know that the previous goniotomies have interfered with the functioning of the angle and causes glaucoma, really. And devices, there's a big concern about that. So really our emphasis is shifting towards transscleral filtration. I'll try to show you a little bit of information about that in just a minute. I have to kind of prep you for that, though. So the first thing you got to know is this is one of the MIGS, you know, just that we use in these studies. The KDB goniotomy, it's a Cahook dual blade. I won't show you the whole video because we're trying to get to the end, right, so we can all go to lunch. But this is the Cahook dual blade. It's a commonly used MIG in the United States. You just pass across this blade and do a goniotomy-like procedure in the angle. And here's another one you got to know for this talk. Anyway, the Zen is a transscleral filtration device. It's made of a small gelatin cross-linked tube. The tube is inserted into the angle, passed into the under the subconjunctival space with an inserter, and left there. It has a 45 micron internal diameter, so it's very safe. We can't get overfiltration, and patients don't have complications like suprachoroidal hemorrhages and things like that, like they do with the larger tubes. So you got to know those two. Okay, so this is just a short study on adult patients, not aniridia patients yet, but I'm going to get to that. On adult, just so you can see where this is going. So the problem with the MIG literature is that everything is done with cataract surgery, mostly that's published. I've been guilty of that myself. I've published papers about cataract surgery and MIGS because that's how it was approved. But we really want to know as clinicians, how do these procedures work without the confounding variable of cataract surgery? So we did a study, and it's in press right now, it's coming out soon, to evaluate the outcomes of standalone Zengel microstent implantation compared with standalone KDB blade for moderate to severe glaucoma. Also, a lot of these things are done in cataract patients that are getting operated on for cataract indications, and they may have mild or little glaucoma, maybe even ocular hypertension. So these are real glaucoma patients, moderate to severe, and no cataract surgery. So this is a paper that's in press, and I won't bore you with the details, but we had two different success criteria, and essentially what we found with this, in regular patients, the long-term results were kind of similar. Both of the procedures lowered the intraocular pressure significantly, and at 2 years follow-up, every patient was followed for 2 years. We found a very similar intraocular pressure between the two groups. The number of medications was initially quite significantly reduced with the Zen, but that drifted back up over time, and at the end of 2 years, they were actually pretty similar in the number of medications per patient. But the really kind of astonishing thing to us was, as we made a more strict threshold for success, if we said that you have to be at mid to low teens and actually have an average pressure under 18 for this study, the transscleral filtration with the Zen was able to achieve that much statistically significantly higher rate than the goniotomy-like procedure. So this is, for clinicians, this would be interpreted to say that if you have patients that you want to achieve a low target pressure in, you're going to have more success with the Zen implant, a transscleral filtration. We can use PreserFlow or Zen or whatever we want to use, or some sort of transscleral filtration. So I'm going to skip ahead to the last thing I wanted to say to you. Again, I'm trying to keep us on time, right? So the Zen versus KDB and Aniridia. Now this is a very preliminary result. What happened is I did about 100 or so patients which we presented at ARVO with the Zen implant, and then I did another, we published this other paper plus some other work. So we've got about probably 300-400 patients. We feel like we really understand these procedures pretty well now. So now we're going into things like Aniridia to understand where they're going, if it's going to help us there or not. So here's a series of, a very small series, less than 10 patients, but I'm adding to it all. This is the ones that I had a year follow-up in. So I'm adding to this all the time now. We're going to have a series. So these are preliminary results. I'm not going to publish these, but they're preliminary results that I'm going to, just to give you an idea of what's happening here, what we're going for. So it was quite clear from looking at our initial few patients that the mean intraocular pressure was more significantly reduced with the transscleral filtration than it was with the goniotomy-like procedure. Again, in the Aniridia patients, they'll tend to have fibrosis, and so you'll see a failure of most of those angle surgeries, which we well understand now. So, but just to show you the comparison. So the KDB also, these are not statistically significant yet, but they will be as they add more patients, I'm quite sure. But the Zen is producing a little bit lower number of medications needed in the post-op period, and that's becoming more evident. And again, as I add more patients, those will become statistically significant. And here's the interesting part too. So at about 6 months, we had a failure of about roughly 2/3 of the goniotomy-like patients, whereas we've still had 100% success with the transscleral filtration. It's only a year. I hesitate to push this too much because I'm just saying that these are rather preliminary results. But this is where we're going now. We're going to be using this. And we feel that there's a place in the care of Aniridia patients for this type of approach, because there are patients that we're trying to get through early childhood. You know, I have patients that are 3, 4, 5 years old that we want to get them a little bit older, you know, and not do such a big thing as a drainage implant. We have patients that are older. We have patients that may actually be successfully treated. I have a young patient who was an infant, recently I treated with a Zen. and has a beautifully functioning bleb. It's not like a trab bleb, but it's a bleb, and has had over 6 months follow-up now. Just didn't quite make a year, but so it's going to have some role where we want to be a little bit less invasive and yet be able to achieve some measure of clinical success. So we feel that this is something where we want to move to in the future. I'm not suggesting that it's going to replace glaucoma drainage implants, but I feel that it will be a significantly beneficial addition to our repertoire for treating glaucoma in these patients. And I think it's going to find some role for MIGS. So that's really all I have to share with you. I think I wanted to just conclude by saying that aniridia is often associated with glaucoma. Open angle glaucoma is the most common type. Just for the physicians here, remember that, because you're going to see the old literature quoted very poorly in your learning materials. MIGS are promising in aniridic glaucoma, especially with the transscleral filtration. Right now, that would be the PreserFlow and the Zen. These are promising to us, and I'd like to thank myself, of course, Aniridia North America, which we've been coordinating with Aniridia Europe, and I'm very grateful to Aniridia Europe for all of that effort and all that collaboration that we've had. It's been great. Aniridic family, obviously, Wagner syndrome, IWSA, VFT, these are all parts of Aniridia North America as well. NIH, PTC provides me support, and my collaborators. I have some very significant collaborators on basic science side, Dr. Lauderdale, who's here, and Granger, and Dr. Cheryl and Kevin Gregory Evans, Dr. Liu and Dr. Zangs for some imaging things that we're also working on to try to help aniridia patients. Anyway, thank you very much for your attention. I'm sorry to push it so far into lunch, and I tried to keep us moving along there. A lot of material. Thank you all very much for listening to it.